Our next speaker today is Dr. Samuel Asirvatham. He is from the Mayo Clinic in Rochester, Minnesota. He will speak to us on MRI-compatible pacemakers. Are they living up to their promise?
Well, thank you very much. So just in the next few minutes, maybe 15 to 20 minutes, going to review some important clinical aspects of MRI and cardiac devices. We'll just review the issue of electromagnetic interference, cardiac devices, what it takes to make a conditional device and what exactly that means, and what can we do with reasonable safety for patients with ICDs, left ventricular leads, or abandoned leads, and other cardiac devices along with a pacemaker or defibrillator when it seems that we need to do an MRI on that patient. So disclosures, I'll point out during the talk any specific device or concept that there may be a conflict. So if we start off, what are we scared about? What is it? What's the problem? General with EMI. So if someone has a device, and whether it's an MRI or something else, and we suspect that EMI, electromagnetic interference, can be an issue, what is it that concerns us? And really, the information on this or the guidelines for this go back a long time. The most concerning things are function that affects physiology. So inhibition of pacing or tracking that actually produces rapid pacing, and either of these give rise to presyncope, syncope, or dizziness. Now, the key to these, I think, are that the symptoms occurring at the time of the procedure should have either an excellent way that you can program the device to prevent it from happening altogether, or you should be able to stop the procedure. And this is what the challenge was for all the years before we thought or had conditional devices. You couldn't always prevent a resetting of the device. So even if it was programmed in a way that may be safe for that patient, if it reset the device, the electromagnetic interference, then it's kind of back to square one. And the second key issue is some aspects of the procedure you couldn't turn off or you couldn't stop. So once you were committed to starting the procedure, if there was going to be a major physiologically significant issue, you were stuck, and it would have to be some form of resuscitation of the patient. Now, all of these are pertinent for magnetic resonance imaging and when you have cardiac leads or cardiac devices in the patient. Asynchronous pacing, rapid pacing, as well as problems with the lead, especially heating at the electrode tip, can occur for a variety of reasons that we'll explore shortly. Give you an example of a recent case. Kind of complicated situation, and decision making was difficult beyond just the issue of getting an MRI. But patient had a prior history of cardiomyopathy, did have previously a left atrial appendage thrombus, and now developed issues that she wound up getting a dual chamber ICD. Goes to an X-ray right after implant, and at that point gets a facial droop and slurred speech. Just had a procedure, so TPA is kind of out of the question, I think. And what is it that's wrong with the patient, and how will you evaluate? So she gets a head CT done, and it's essentially